Thank you very much. So, yeah, I'm filling in for Jo, and although her talk was going to be mainly focused around the biomechanics and maybe some of the biomechanical rationales for some of the treatments that Micah and Lars will talk about, I'm going to talk a little bit about biomechanics, but also a lot about pain. What is this common knee pain complaint that we're actually talking about, and who are these patients? So more of a broad overview of patellofemoral pain and these patients that then Micah and Lars are going to delve a little bit more into the treatment side of. So I had to come up with a new title for my talk, and we came up with patellofemoral pain, more than just knee pain. Is this one linked in? No, it's not. Oh. Perfect. So the main question that I'm going to focus on, hopefully as a nice introduction to the session, is who is this patient with anterior knee pain or patellofemoral pain, as most of us would call this type of pain complaint? Who are we actually talking about? Well, first of all, what is patellofemoral pain? Patellofemoral pain is pain in and around the kneecap. It's also called maybe kneecap pain. That is around the patellofemoral joint. And this is, there's consensus on how we diagnose it. It's an umbrella term for insidious pain around the knee, effectively with no other clear diagnosable pathology. And it's pain that's aggravated by activities which load the patellofemoral joint, typically, such as squatting, stair climbing, and other knee flexion activities. And when we ask the patients where they feel their pain, yes, they say it's around the kneecap. But it can be all around the kneecap. So this is an overlay of a lot of different patient presentations of where they feel their knee pain. And Chris Powers, as part of the patellofemoral consensus document, developed a pathomechanical model from a biomechanical perspective of why would you develop patellofemoral pain. And this includes both some of the abnormal pathomechanics, anatomical variations, which Lars is going to probably delve into a little bit later in this subset of patients who have specific anatomical abnormalities. But it also focuses a lot on the movement characteristics of those with patellofemoral pain and how they load their knee joint differently. And you can see it's a little bit complicated here. We have a lot of different interacting factors and relationships, but effectively the concept is that if you move differently, you load your knee joint differently, this is going to increase the patellofemoral loading and stress and eventually result in patellofemoral pain. And a lot of the concepts that have gone into this model have been developed off cross-sectional studies which show that, yes, people with knee pain move differently to those without knee pain. But the question is whether or not these are prospectively associated with patellofemoral pain, if they actually do increase the risk of developing patellofemoral pain. And we do have a little bit of prospective evidence to guide us on that conclusion. So there are a couple of studies which have done prospective investigations of biomechanical risk factors for developing patellofemoral pain. And what we can see is that it typically does characterize what we think of the typical patient with patellofemoral pain, who is characterized by increased hip internal rotation. We see a large valgus angle usually, and also some biomechanical differences at the foot as well. So these have been prospectively linked with the onset of pain. They've been done largely in small studies, and the effect is quite small. And the question is this all there is to it? From an engineering and a loading perspective, it makes sense that if you load the joint and increase the stress, then you might end up with some pain. And the way we move affects where we distribute the load. But then there's also the absolute load that we expose the system to. So in terms of, we often see patellofemoral pain in runners who have just started start to run programs, who've had rapid increases in training load. And we don't have a super strong patellofemoral literature, but we do, from other areas, know that rapid increases in load can increase the risk of injury. And I think that's quite sensible. So there's two things here: how you move and then the overall load that you're exposing it to. And again, these are all based on the premise that you have a stimulus, you have a mechanical input, and then you have the output, which is pain. And this is something that I want to challenge a little bit here, because while that is, of course, important, there's other things going on here. We know that once you have pain, you're going to have some psychological and behavioral and cognitive factors also associated with that. And we don't purely think of pain in terms of biological stress. We also think of it in the concept of the biopsychosocial model. And so that's what I'm going to talk a little bit more about now. The thing about patellofemoral pain is the prognosis is notoriously poor. It's extremely recurrent. Maybe this is because we can't get rid of those bad biomechanics, but maybe there's some other factors that we also need to consider in the recurrency of this condition. So some of Michael's work has shown that approximately 50% of patients with patellofemoral pain will continue to have pain 5 years later. So the question is, we have a lot of other long-standing musculoskeletal pain complaints, such as low back pain, also kind of a non-specific pain complaint. And can we draw any parallels between the literature in these and also look at the patellofemoral pain specifically? And we were interested in doing this again in a 5-year follow-up of a large cohort of young adolescents with knee pain. And what we could see was that at the start, when they were recruited by Michael in 2011, the majority of them just had knee pain. They had a localized knee pain complaint. But because the prognosis is poor, they had pain for a long time. A lot of things happened in those 5 years. Then we completed in 2016 the 5-year follow-up, and what we found was that they had actually moved in a trajectory of having more pain at follow-up in a lot of different locations. And again, if we draw some parallels to other musculoskeletal pain literature, we know that having pain in more than one location is often associated with a poor prognosis. So we wanted to ask the question, in this patellofemoral pain adolescent population, are these who had pain in more than one location at baseline, was that associated with their prognosis? And effectively, the answer is yes. So what we found was that if you were an adolescent female, you had an increased risk of poor prognosis. But if you had pain in more than one location besides the knee, this is going to increase your risk of a poor prognosis by an additional 25%. And this is in a condition that has a very, very poor prognosis to start out with. So what you can take from that is basically if you're a young adolescent female with pain in more than one location, as well as patellofemoral pain, you're pretty much guaranteed to have pain 5 years later. So this raises the question that if you have pain for a long time, 5 years, that's a long duration to expose yourself to pain to, and you have pain also maybe spreading to other locations, then what does the actual pain system look like? And this is something that that we just conducted last year. So this is unpublished work that I'm working on right now. And we recruited basically 87 females in total. And we had one group who had long-standing patellofemoral pain since adolescence. So these are young adults in their early 20s who have had pain for more than 5 years. So a lot of them have had pain for nearly 1/3 of their lives. And then because patellofemoral pain is extremely recurrent, we know that you've had a previous history of patellofemoral pain. It's one of the strongest risk factors for a subsequent experience of it. So we were also interested in looking at those who had a history of pain during adolescence, but now report themselves as being recovered, or my knee pain's gone now, I'm all good. whether or not that you can be fully recovered is another question we can leave for the discussion. And then we had this super healthy control group with basically, with basically no history of any musculoskeletal pain complaint. So that was our control group. And we wanted to undertake quantitative sensory testing, which is a way of looking at pain sensitivity and pain perception in these individuals and see if there were any differences between the groups. We had a blinded assessor, Christian Strazak, who's sitting here in the audience. All the instructions were given in Danish, so although I'm here working in Denmark, I wasn't quite there yet. So what we did was, for those of you that might be familiar with pain sensitivity, we want to look at pressure pain thresholds. So what is the magnitude of stimulus you need to input to actually activate a pain response? So this is done locally at the knee, as you can see here, by slowly putting pressure on a location, and you're fitted with a switch, and you basically press the button when you feel the first onset of pain. And we will call this the pain threshold. And we did this locally at the knee, and I guess it's maybe sensible, that's where they have their pain. But we also do it at a remote site on the arm, which would be more reflective of whether there was widespread changes in pain sensitivity, which gives us an indication of some central pain mechanisms. In addition to this, we have what we call temporal summation of pain. And basically what this is, you can see across here, we give 10 stimuli very close together, all of equal intensity. And then you ask the participant to rate how painful they are. And they're of the same intensity, so the pain should be the same. But what we see is that we can see a facilitated pain response, which is that pain can increase over these 10 stimuli, which gives us an indication of some of the bottom-up central pain mechanisms. And this has been done in a lot of other chronic, long-standing musculoskeletal pain conditions, such as knee and hip osteoarthritis. And what we can see is that those who have knee and hip osteoarthritis have a more facilitated profile. So they have this is pain here, so they have an increased pain response over these 10 stimuli. And then the other outcome we were interested in looking in is condition pain modulation. And this is basically, if you stub your toe, you have some pain. And then if you want to make that go away, you can maybe bite your finger. Because if you have a second painful input, this is like our top-down endogenous pain inhibition. So this gives us a good reflection of the central pain system. So we undertook this basically by having 2 cuffs on the lower limbs. One of them was inflated to a constant painful pressure. The other one slowly increases, and you see when the first onset of pain is. So these were the outcomes. And effectively, what we saw is that those with patellofemoral pain that had long-standing knee pain had a reduced pain threshold. So they were more sensitive to pain at the knee joint, which is probably not surprising. That's where they had their pain, compared to both those who were recovered and the controls. They also had some segmental spreading of this, which is indicated by reduced pressure pain thresholds also lower down the lower extremity, as well as having reduced pressure pain thresholds at a remote site on the contralateral elbow, indicating some widespread changes. And maybe the most interesting thing here is that those who are recovered, on all of these, they fall right in the middle between the unhealthy ones and the completely healthy ones. So it seems like they might be going back to normal, but they haven't quite reached it there yet. And then if we look at the temporal summation of pain, so here you have the 10 stimuli all given at an equal intensity. And what you can see is that we have a more facilitated pain response in those with long-standing pain relative to the control group. And again, the question is, what about those who are recovered? We know that patellofemoral pain is extremely recurrent. Where do you think they're going to fall on this graph? Are they going to be the same as the healthy participants if they no longer have pain? And they actually had as equally a facilitated profile as those with long-standing pain, despite that they reported being currently pain-free for an average of 2 years. And this might give another rationale as to why patellofemoral pain is such a recurrent condition. Because if you have a reduced sensitivity to feeling pain, then that might increase your risk of subsequent episodes of pain. And then with conditioned pain modulation, so another central mechanism, top-down, pain inhibition, what we could see was that we had differences between those with current long-standing pain. And this is a really, really special group because we recruited 36 who had long-standing pain. They had pain for an average of 8 years, so that's a really, really long time. And despite that, they started out with a localized diagnosis of patellofemoral pain given by a rheumatologist, primarily at the knee joint. Again, now at this point in their early 20s, they have pain in a lot of different locations. 60% of them had pain in other places other than their knee. And these were the most common additional locations in and around the hip, the back, the shoulder. And worryingly, 7 of them, so nearly 1 in 4, actually fulfilled the criteria for having a widespread pain condition. So there's a lot more going on here beyond just pain at the knee joint. And when we talk about pain distribution and pain spreading, having pain in additional other locations, what we can see with patellofemoral pain is that A, it's very variable where they experience the pain, but Shelley Bedreau and Michael Rathleff published this study where they actually looked at the spread of pain around the knee joint, and they could see that with longer duration of pain symptoms, that the pain was starting to move into a more oval pattern around the patella, indicating some sort of spreading of the pain. But that's all very, very strongly still related to the bio side of pain. And as I said, I wanted to talk a little bit about this in the context of the biopsychosocial model. And in a lot of other musculoskeletal complaints, we know that there's psychological differences. But what about patellofemoral pain? We don't often think of these patients in terms of psychological differences, do we? So Liam McLachlan is one of Bill Vicenzino's PhD students. He's going to be the new guy in this area. He's got a lot of super up-and-coming work. But at the moment, he's published this systematic review where he's looked at whether or not there are differences between those with patellofemoral pain and controls in terms of psychological characteristics. And of course, what they found is that those with patellofemoral pain have more anxiety, depression, and altered cognitive profiles. And the question that I want to ask to both Michael and Lars is, you're going to talk a little bit maybe about some exercises and about some surgery. And do these interventions actually encompass some of these other characteristics that we see in these patients with long-standing pain? So I'll be a little bit of provocative to my co-speakers here today. So I think this is the main finding is that right now we know that this is there, but actually we don't really know what to do about it because it's under-researched and it's also underappreciated. And then, maybe not surprisingly, we also asked them how they sleep. And sleep is really, really important. It's one of the pillars of health, and perhaps not surprisingly, those with long-standing pain sleep a lot worse than their peers without pain. And some simple questions that we asked, and we could see that they had significantly worse sleep. And I think this is, again, really important because we know that if you sleep poorly, that's also going to affect your next day pain. And it's like a vicious, recurrent circle. So this is something else that we might need to think about in the context of patellofemoral pain. So yeah, I'm just going to pose the question to Michael and Lars. Does it make sense to only focus on exercise or surgery, both of them targeting some of these mechanical factors associated with patellofemoral pain, or are there some other things we need to also consider in our interventions? So to sum up, who are those who are characterized by long-standing pain? Well, they're mostly female. We know that being female increases your risk of having most musculoskeletal pain complaints. They have a lot of pain in other locations, especially after they've had pain for a long time, and we can see some sort of spreading. And this might be reflected or due to the decreased pain sensitivity that we can see. And the pain sensitivity is quite interesting because in other chronic conditions such as knee or hip osteoarthritis, this temporal summation of pain, which is a central mechanism, it's also been associated with poor prognosis after surgery. So whether or not they they are successful responders to total joint replacement. So maybe it's something we need to look at a little bit more in this population as well. And then we need to consider other concurrent problems in the context of the biopsychosocial model. So we know right now that there are some psychological differences, but we don't have a huge amount of evidence to guide what we do with that in a treatment context. And I guess the sum up that I want to say is this patellofemoral pain. It's like an umbrella term of knee pain. And it's a really heterogeneous group that we're looking at. And maybe the patients that Michael sees aren't the exact same as the patients that Lars sees. So we need to think of all of these factors in the context of the biopsychosocial model, because in each patient, it's probably going to differ how much of these are going to be the predominant factors in their presentation. So, in summary, there may be many reasons why they develop patellofemoral pain. Some of them might be related to biomechanics, but there's also probably many other reasons why they still have it for such a long time and why it's a condition associated with such a poor prognosis. So, thank you.
Thank you very much. Do we have a quick question while Michael is preparing for his talk? It was crystal clear. Thank you so much, Simit.
Yes. So I got an email a while back from Kristoffer, and she said, "Michael, I have a good idea for a symposium. Wouldn't you like to answer the question, should the physiotherapist keep the patients away from the surgeon? Please be aware there'll be quite a few surgeons among the crowd, so be careful what you say." So that was a nice, tough challenge by Kristoffer. So what I'm going to talk about for the next 12, 15 minutes is just looking a bit into the clinical care pathway. How are these patients with patellofemoral pain actually managed today? What's their road through the healthcare system? Want to talk a bit about the evidence for managing patellofemoral pain, focusing on these physio interventions that some might use, and then finally try to come up with an answer to the question that Kristoffer proposed. So this is a participant from one of our ongoing studies from the APA cohort. It feeds quite nicely into what Sinead told us about the spread of pain, multi-site pain. And this is also a group that we're looking into from a more qualitative angle, looking at how does pain, living with knee pain for such a long duration, actually impacts you. So she said, it's like the pain started in my knee, then it spread, and now it's everywhere. So these are the data. We use an app called Navigate Pain to collect where they experience their pain. And this were where she experienced pain. And of course, these are one of the participants that would be categorized as having widespread pain according to the ACR criteria. If we're looking at I'm cherry picking now. This is one participant. Looking at her road, her path through the healthcare system. When she was a young kid, she saw her GP a couple of times. At first, we took a wait and see approach. Come back if it doesn't resolve. Reduce your activity levels, maybe use a couple of NSAIDs. She came back, said no, didn't really work. Then she was referred to an orthopedic surgeon. The orthopedic surgeon referred her on to an MRI. Took 4 weeks before she could get a time for an MRI. 4 weeks of distress, being anxious about, I have to look inside my knee to see what's wrong. She got the response. There was nothing on the scan, to no one's surprise. Then she was sent to the rheumatologist. Couldn't find anything. To a physio. Physio prescribed some straight leg raises, some stretching. Didn't really work. Back to the GP, and then finally she lost faith. So this resulted in increased worries, negative beliefs about her ability to actually cope and manage her own knee pain. And she was super frustrated because all the different healthcare practitioners that she saw throughout these 4 or 5 years, they gave her mixed messages. Some would say anterior knee pain, it's self-limiting. Some would say this is growing pains, you don't have to worry. She got mixed messages, got confused, had a hard time navigating in a complex healthcare system when you're a young kid. So the essence was a complete lack of faith in change. And this is cherry picking, of course, but this is actually reflective of some of the young kids, even also older adults we see with patellofemoral pain. To look more into how are they actually managed today, we did a study where we got the opportunity to look into GP records of how these patients were managed. And these are a group of 121 that we used for an RCT we did a few years ago, and then we went back in time looking at their previous contacts into the healthcare system. What we saw was that because these were all recruited from schools, so there was no selection bias in terms of only recruiting through primary care or secondary care. We took everybody with patellofemoral pain from the schools. Then we could see that despite having pain, roughly 60 of the 100 that we surveyed contacted their GP to get advice on how to manage their knee pain, while 35 actually didn't even seek medical contact. Some of the reasons were that it's growing pains. Your parents tell you that we don't have to bother our very, very busy GP because it's part of adolescence, it's part of growing up to have knee pain. So that's some of the reasons why they didn't take contact to their general practitioner. So the others that actually got into general practice, the most common way to manage them was with information and advice. I think that's very, very sensible. Some were prescribed painkillers, and for some, there was no treatment initiated because let's see and wait this out. And then some of these, 26 out of the roughly 100, received a referral. Some received it at the first contact into general practice, while some received a referral at the third contact. If you see here in the bottom, quite a range of different referrals. Some are referred to physiotherapy. A few were referred to having an X-ray, some to the Department of Rheumatology, and then we had a group also here that was referred to the orthopedic department. And my take from doing this study is that the clinical care pathway today is very, very heterogeneous. They're managed in a number of different ways, which is to no one's surprise, of course, but we have to consider what's the optimal clinical care pathway for these. Should we have referred some to Lars early on? Should we have kept them in general practice for a longer time? How to best organize the clinical care pathway for this patient population. And secondly, I think this is something that also feeds into the discussions with Lars is, depending on where we work in the healthcare system, we might see very, very different patients. It looks like the ones that go down here, they're the more severe cases. They're not your typical patient you would see in a side court, playing handball, playing football. They might not be reflective of the general population in general practice. So depending on where we work, we might see different patients. And I think that will be important when we discuss afterwards the patients that Lars see compared to the patients seen in general practice and in physiotherapy departments in secondary care. And the reason why this is important is then we follow these kids over time, these young adults. We can see, as Sinead said, that roughly 1 in every 2 will continue to experience pain. And it's pain more than just pain. It's actually pain that impacts on their young lives. It affects their choice of job, career choices. A lot of them stop or reduce playing sports due to their knee pain, and then 1/3 regularly use painkillers to self-manage their knee pain. They shop around, they continue to seek care, seek advice, go to different people asking advice on how to manage the knee pain. When we follow kids or adults over such a long time, of course we have to think about, when do we consider exercise therapy or some of the other interventions, foot orthoses, when do we consider it non-successful? When it is we should think this patient might need to be referred to other healthcare practitioners through in collaboration with the GP, because the interventions we are prescribing are not having the intended effects. But if we then take the promise that we should refer on to Lars, for example, what's the evidence from RCTs on the effect of surgical procedures for this patient population? There's actually only one good RCT, and that was a Finnish study, quite a highly cited paper after all. And what they did was that they took a group, 48 patients or 50, and randomized them into exercise therapy and then added on knee arthroscopy. They looked at both short-term outcomes, adverse events, and also here they have the 5-year follow-up on what's the clinical outcomes. You don't have to read all this, but the main point here is there's no difference between the groups. There's no added value of a knee arthroscopy for this patient population. The only major difference was there was a heaps of adverse events or more adverse events in the group receiving knee arthroscopy compared to those getting exercise only. But maybe another point and take from this is that even when they survey them 5 years after the treatment, they're not super well. A significant proportion will continue to experience pain and symptoms, even despite we were offering them what we consider evidence-based treatments today. I don't know if you saw the big RCT study from Mark Matthews, 220 patients roughly randomized into 2 of the interventions we consider evidence-based good interventions, either exercises around the hip, a really good exercise program, or foot orthoses. And even this big group, only 40% are actually better after 3 months. And it fits very well with the literature that if you just survey the whole literature looking at the long-term prognosis, 1 in every 2 will continue to have pain even following years later. So maybe we should also question ourselves if we found the silver bullet for how to manage these patients, because I don't really think that our interventions today, if I'm critical towards my own research field, really encompass all the things that Sinead previously presented. This is more than just a knee, and it's more than just knee pain. So the current recommendations today, just to what's the evidence out there, part of this group, a group we meet every 2 years. Last time was in Australia, an amazing conference at the Gold Coast, where we discussed everything related to patellofemoral pain, how to manage, what's the evidence, where do we need to go to next. And then we try to sum it up in these publications, which are open access on British Journal of Sports Medicine, so it's super good. It's around terminology, it's about definitions, and it's about interventions as well. The current recommendations that came from this, which was a synthesis of both the research evidence out there, but also linking it in with experts at the retreat, is that we have 6 overarching recommendations for managing these patients with patellofemoral pain. And one is exercise therapy, recommended to reduce pain in the short, medium, and long term. Combining hip and knee exercises appears to be more efficacious compared to just focusing on the knee itself. And then we have this third one, which is related to combined interventions. They're recommended to reduce pain. And when we talk about combined interventions, it's basically throwing everything at this patient population, including exercise, patella taping, education, whatever we could do. a bit about foot orthoses, and then importantly, knee and lumbar mobilizations are not recommended, and electrophysical agents are not recommended. We didn't dare to put in a seventh one on surgery. I'm looking at you, Lars. No, but even though we have evidence to support these interventions, we also have to be critical because it's not a silver bullet. If we look at the evidence that underpins these recommendations, the key thing is they're better compared to doing nothing, but it's clearly not something that will help all of our patients. That's why I think it's very timely that we consider looking at this patient population from a pain perspective today, a exercise therapy physio perspective, and then ending up with a more surgical perspective on things to talk about how can we manage these patients that might not respond to some of these more simple non-invasive treatments that we're prescribing. And also talk about the clinical care pathway, because that's where I think we can also benefit or make benefit to our patients, talking about how do we actually structure that in a healthcare system. One of my takes on that, if I had to give you a couple of simple take-homes also from this, would be that early on when we see them side court or we see them in general practice, we just do the simple stuff. Load management, education. We've done that in a couple of studies. It actually seemed to have quite a good effect if we catch them early and teach them how to self-manage their pain. If that's not successful, then we can start to add on more expensive, more complex interventions as supervised exercises, including hip and knee exercise, maybe foot orthoses, some of these passive adjuncts. But when is it that we consider the simple stuff non-successful? I don't know, maybe that's up for discussion later today. When is it we should say, okay, now we try the simple stuff, we need to look at more expensive, complex interventions. And of course, when I propose something like this, I always suggest it should be delivered to the patient with your clinical expertise, taking in context the patient preferences as well. Because as Mark also alluded to yesterday, this is also about shared decision making. If we have two interventions that roughly provide the same outcome, then it should be up to you and the patient to decide what to do. But this group over here, when is it there's an extra arrow up for a referral, for an examination to tease out, are there other reasons why they still have pain? Is it something with the pain system? Is it something localized at the knee? To sum up the take-homes and giving a perfect pitch to Lars is that we actually have strong evidence for a positive effect of these different non-surgical interventions. But we do miss and we do have a lack of when the exercise therapy is non-successful. When is it we should consider to refer on and bring in other healthcare practitioners? And I think we need to consider the clinical care pathways, thinking of how we can put this into the context of the healthcare system, making sure that this young person who was sent flip-flopped through the system, that won't happen. Because that's also where we induce poor long-term outcomes by giving these mixed messages to these young patients. So the answer to the question is non-surgical intervention has a lot to offer, and current evidence do not support surgical interventions. So I think physios should try to keep the patients, try the simple things first. We should do that and we should do it well, but we also need to be critical towards own practice and think of when is it actually essential that we bring in other healthcare practitioners instead of just continuing month after month with knee or hip exercises or trying out foot orthoses. So maybe Lars has an idea of when we should refer, when is it meaningful to bring in other healthcare practitioners to look at, can there be other reasons that can be solved by other means? Because a key thing from all the studies is these patients don't do well long term. So we need to come up with new ideas for how to manage these patients. Thanks.
Thank you very much, Michael. Michael, I have to ask you a question while Lars set up. You have shown that half of the patients, they don't do well. And you have shown with time that the pain spreads. Could it be that by keeping them in physiotherapy, that you induce this pain in the patients, which spreads and then become incurable? Could it be that instead we should turn it opposite and they should go to Lars first? And Lars, he could fix the biomechanics of the half part that do not get well, and the parts who do not have biomechanical problems could go to you and have physiotherapy.
Flipping it around, I would actually think that we are currently also over-treating these patients. I think we're focusing too much on supervised, bringing them to a healthcare practitioner. I think we need to turn it around and thinking, how can we actually encourage their self-management early on? In some of the new studies we're doing, looking at how we can increase your ability to manage your own knee pain, we actually get much better outcomes compared to some of our previous supervised interventions. And one of the things is that what we can see is these patients, when they go to a physio for a number of times, they become addicted, not addicted, but they feel they need to see and train with the physiotherapist. They feel they need to see this expert to help them manage their knee pain. But if we turn it around and think, how can we encourage their self-management early on, I think that's also where we can improve today. If we should refer them on to Lars, I would be hesitant to ask that, but maybe Lars had a point on that.
I will see much too many patients. No good idea. So thank you, Kristoffer. I'm very grateful to give this talk on anterior knee pain and surgery. It's a very controversial topic. It's a topic with, compared to what we have heard the other days, there is very low evidence. However, for the biomechanics, there are becoming more and more evidence that biomechanics are involved in this. I want to start out with this case. This was a girl or a woman, 36-year-old. 3 weeks ago, I gave this girl a patellofemoral arthroplasty. She had had severe anterior knee pain for 20 years that really have impaired her life. She had tried everything. I just want to ask, do you think it's fair that you're going to live 20 years with severe anterior knee pain, and then in the age of 36, you are having an arthroplasty? So, for many years, we have thought, is there a link between anterior knee pain and developing patellofemoral osteoarthritis? Because when we do patellofemoral arthroplasty, the patient tells that they have pain in adolescence. And this study here tells us that if you have anterior knee pain in adolescence, you will have a 7.5 higher risk of developing patellofemoral osteoarthritis later in life. So lately, Michael and I, we did a paper together, and Michael very clever said to me, I think we see the elephant from different views, and for sure we do. Remember, anterior knee pain is a symptom. It's not a disease. It's just like abdominal pain. It's a disease, but there are many causes. And we know functional malalignment that can be treated very well by physiotherapy. But we have to realize that there are many other causes for having anterior knee pain. And Sinead briefly mentioned these factors: sagittal malalignment, frontal malalignment, transverse malalignment, and there are other cases as well, such as synovial plica. And somehow I regard anterior knee pain as very close related to patellar instability, because the biomechanics are the same. And somehow you can say that anterior knee pain is a patella that just hasn't dislocated yet, and perhaps never will. So why do you get this pain? I don't know, but this is my own theory. You can have increased patellofemoral pressure. We know that is a factor in many of these patients. That causes cartilage wear. This causes cartilage debris. We know that causes synovitis and inflammation, and thus causes sprouting of nerve ends and pain. You can have maltracking, the same. You can take the other pathway. This causes osteoarthritis, that causes increased subchondral pressure, and we know that causes pain. So what is malalignment? It's the same as maltracking. The patellofemoral articulation is somehow abnormal. This gives rise to increased forces and pressures and increased wear. You have to look at this in 3 planes, and that makes it really, really complicated. For the frontal plane, it's quite simple. We have the valgus knee, we have the increased TGG distance, we have the increased femoral anteversion. For the transverse plane, it's typically the patella alta, and that means that the patella has not engaged proper into the trochlear groove. That means the contact area between the cartilage in the trochlear groove and on the patella is very low, giving very high forces. And the pressure on the corpus Hofer increases a lot. The Hofer is the airbag of the knee. This causes inflammation, and we see it on the MRI as Hofer impingement. Then there's the sagittal malalignment, and this is even more complicated. You see, this is a normal trochlear. In this case, there's trochlear dysplasia. That means there's too much bone. The distance here is higher. That forces the patella forwards. That means that the angle here is less, and this has been documented in this study. So what is the natural history? We have heard it. This was where I started out more than 20 years ago doing my first study, and we saw 250 patients from a sports clinic, and actually 13% continues to have the same or even worse pain 6 years after. And perhaps this is the ones where we should consider surgery. Same has been documented in other papers. So just to mention a few of those biomechanics studies, this study, they looked upon how do patients who failure conservative treatment, how are they characterized? And they found that among those having a TGG above 14.6 millimeter and chondromalacia on the patella, there was a 100% failure of conservative treatment. Just to remind you, the TGG is the distance between the trochlear groove and the tibal tubercle. The other study here, they compared a group of normal patient or normal individuals to patient having anterior knee pain, and they found that the lateral trochlear inclination angle was significantly lower in those having anterior knee pain. And the lateral trochlear inclination angle is the angle of the trochlear, the one who should stabilize the patella. And if the lateral trochlear inclination angle is below 11 degrees, we call it dysplasia. Normally, this is 21 degrees. So the lateral trochlear inclination angle actually defines trochlear dysplasia, and it correlates to anterior knee pain, but it also correlates to cartilage wear in the patellofemoral joint and the development of patellofemoral osteoarthritis. And if you look at those having a patellofemoral arthroplasty, the lateral trochlear inclination angle is low in 78%. And now to something else. This is the miserable malalignment, and this is seen quite often in among pediatric orthopedics. The anteversion is normalized in most individuals through the teenage years. However, if you have a knee like this, severe femoral anteversion, and the tibia has compensated by increased tibial external rotation, it looks like this. And what happens is that the forces here increases, and you will get wear in this area and pain. This is a patient with a CT scan with severe increased femoral anteversion. So just to summarize, we have the patellar ulcer, we have the trochlear dysplasia, we have increased TTGG, in many cases based on increased tibial external rotation. We have increased femoral anteversion, and then we have the hyperpressure syndrome. Naturally, I believe that all these patients should try to undergo physiotherapy before you even consider surgery, because 50% respond very good on that. So then we go to the surgical option, and as you see here, there's a lot of surgical option. And naturally, you have to tailor the right surgery for the right patient, and this is really complicated. As Hippocrates say, first we should do no harm, and there's nothing you cannot make worse by surgery. So if you don't know how to manage these patients as a surgeon, you should stay away, and you should try to focus on this, developed by Scott Dye, the functional envelope, meaning that you should not increase your load, you should not increase your frequency, you should stay in the zone of homeostasis, otherwise you will get into the zone of supraphysiological overload or in the zone of structural failure. That basically means that the patient is going to live with the pain. And the Patellofemoral study group, their general opinion is never operate on patient with anterior knee pain. I very much disagree with that, based upon the first case I demonstrated to you. I think that some of these patients actually can be helped by the right surgery. This is not really surgery. This is a study from Joanne Stevens. Unfortunately, she is not able to present her very good study on this. This is simply Botox in the vastus lateralis, meaning that the load on the lateral retinaculum is less. And in cases with hyperpressure, they have demonstrated that even after 5 years, they still respond very well on this. You can also do a lateral retinacular lengthening when you have hyperpressure. This is a randomized study where they looked upon lateral releases, the one that used to be done in many of these cases, and in many cases the patient become worse. But for the right patient with hyperpressure, it's a very good procedure, but you should do the lateral retinaculum lengthening compared to the lateral release, demonstrated in this study. So then there's a study that Michael, it's actually demonstrate how bad you can do a study. If you compare anterior knee pain to abdominal pain, I mean, if you have abdominal pain, no one wanted to look into the abdominal cave to see where does the pain come from. I mean, if you have these patients, it's very, very seldom that you can help them out just by an arthroscopy. There are some cases where you can do that. If there's no malalignment, they just have condylation and crutching, you can go in with an arthroscope and do debridement. In this study, randomized study, they compared debridement using a shaver and a radiofrequency device and demonstrated that they responded better on radiofrequency debridement. Then there's the focus on osteotomy. And this is a surgical procedure in those patients having increased TTGG distance. It is mostly used for patients having beginning osteoarthritis in the patellofemoral joint, and you can move the patella into an area where the cartilage is okay. And there are several studies out there, case series demonstrating fair results. However, a quarter will not undergo the procedure again, and in this study, 28% failure. However, those studies have not looked into the TTGG distance. If you do that, I think the results will be better. I do quite a number of these surgery, and it is an okay surgery, but somehow it is salvage surgery. Then there's a patellar alta. And just one thing, never look into the Insalsavati and Caton de Champs index. Those indexes are foolish. What it's all about is the overlap between the cartilage in the trochlear and the cartilage on the patella. You see, this case, it has obviously a very high patella. But the patellar-trochlear index is normal. That means that the trochlear engages, the patella engages properly into the trochlear, and the overlap is fine. But if you use the Caton de Champs index, you would say that this patient needed a distalization, and you will end up with a very bad result, I can tell you. So this study looked at the outcome after distalization of a patient having patellar alta, and they found pretty okay results, and I have the same experience as long as you do not take down the patella too much. If you do that, you will end up with a patella bia, and you are really in trouble. Then there's a femoral anteversion, and the Germans do a lot of those surgeries. We are not very keen to do that in Denmark and not in other countries as well. But the German has demonstrated very good results. This is just one study demonstrated that the VAS score goes pretty much down. You may think this is a major surgery. However, those patients go home the same day, and I think they respond very well on this surgery. Then there's tibial rotational osteotomy. This study compared medialization of the tibial tubercle and the tibial rotational osteotomy, and found that there was significant better results if you did external rotation of the tibia. Then there is my own very little series. I'm the only one in the world who do this surgery just for anterior knee pain, and I've only done a few cases, but the patient has responded very well. You see, this is a dysplastic trochlear, and after the surgery they have a normal trochlear, and the patellofemoral pressure decreases and the pain is away. The first patient I operated had anterior knee pain for 20 years, and immediately after the surgery, the pain was gone. But it is experimental surgery, and the problem with all these surgeries are there are so few patients. So to do randomized studies, it will take me 3 lifetime careers to do those randomized studies. So, my take-home message, if you have patients having chronic anterior knee pain, at least go for further examination. And you should keep the patient away for the surgeon who do not understand what is the pathomorphology. Otherwise, you will end up with the results worse from beforehand. Thank you.